A very good morning to all of you, and greetings from the academic subcommittee of the GMOA. Today's topic for the academic hour is dermatological conditions not to be missed at primary healthcare settings. The resource person for today's lecture is Dr. Indira Kahavita, who is the consultant dermatologist attached to anti-leprosy campaign. Dr. Indira Kahavita is the immediate past president of Sri Lanka College of Dermatologists and also a member of WHO Technical Advisory Group for Leprosy. She held the post of Secretary Sri Lanka College of Dermatologists for 3 years consecutively from 2012 and was the chairperson of the Leprosy Study Group of the Sri Lanka College of Dermatologists. Dr. Kahavita is an executive committee member of the South Asian Regional Association of Dermatology, Venerology and Leprosy from 2017 to present. She also has co-authored 3 books and guidelines on leprosy, which has been published by the Sri Lanka College of Dermatologists. She also has authored several international and national publications on leprosy and leishmaniasis. With her expertise in leprosy and leishmaniasis, she has attended and delivered presentations at several meetings, including the International Leprosy Congress, International Conference on Tropical Dermatology, Asian Dermatological Congress, Annual Scientific Congress of the Singapore Dermatological Society, DermaCon International, and also Dubai Derma, which was held in 2021. So let's warmly welcome Dr. Indira Kahavita for today's session. And if you have any questions related to today's topic, please send them over through the chat box, and we will attend to those questions after the lecture. Over to you, madam.
Thank you, Charuni, for that kind introduction. Very good morning to all of you. So today I thought of sharing a few cases with you and like discussing certain points which are of importance, like differential diagnosis, where we can go wrong, what we can do in the primary care setting for skin diseases. Yeah. So we will start with case 1. This is a 13-year-old boy with a hypopigmented patch in his left temple for 8 months. So I have 2 questions for you, like since we cannot answer questions here like on a live platform, I would like you to think of the differential diagnosis here and to think for yourselves how you differentiate these conditions. This patch has been there for some time. This is a fairly well demarcated lesion. And when we did the sensory testing, there was a mild sensory impairment in this lesion. So this was a case of tuberculoid leprosy. So what are our differential diagnoses? Now, how do we differentiate between tuberculoid leprosy and something like the first picture, where you get, this is actually what we call pityriasis alba. It's a form of photodermatitis occurring in young children who have dry skin or atopic, what we call an atopic diathesis, where you have a tendency to develop asthma, allergic rhinitis and atopic eczema. So children with dry skin, when they are exposed to the sun, they develop these fairly ill-defined white patches which are usually confined to the upper face, upper half of the face, usually the cheeks, the upper part of the cheeks. Because these are photo-induced lesions, usually the chin and the lower cheek are not affected in pityriasis alba. Sometimes when you touch the lesions may feel somewhat dry and scaly. This is something that we share with lesions of leprosy also, the dryness, but scaling will not be seen in a leprosy lesion. Now the second picture shows pityriasis versicolor. Here you can see the well-defined lesions. So leprosy is also well-defined usually, but on a lesion of pityriasis versicolor, you would see fine scaling as if like you have spread flour on top of the lesions. So that scaliness is something that gives away the diagnosis of pityriasis versicolor. And usually versicolor is you get multiple lesions, but in tuberculoid leprosy you get just 1 or 2 lesions. And if you question the patient, they will say it's usually not itchy, but there will be itching when the lesions are wet, such as when they are sweating or just after a bath or a wash. So that is how you differentiate between pityriasis versicolor and leprosy. The first picture here is actually, it doesn't contain all the typical features of an achromic nevus, but this is a depigmented nevus, or we call it an achromic nevus. The typical feature there is, if you look at the edges of this, like these are very well demarcated lesions, there won't be any sensory impairment. These are asymptomatic lesions like leprosy, but the edges are serrated. So these serrated edges are the feature that we use to come at a diagnosis of achromic nevus, but obviously the lesion has been there since birth or from very early childhood, infancy. Usually what happens is the mother may not have noticed the achromic nevus at birth because the child's skin is quite pink. A newborn skin is pink and fairly transparent, so these pigmentary changes may not be obviously seen in infancy or in a neonate. So if the mother has noticed this since infancy, it's very unlikely to be leprosy. The second picture here is that of vitiligo. Here you can see that it is depigmentation rather than hypopigmentation, but here in the lower part of the lesion, you get a somewhat ill-defined lesions also, and you get a part which is depigmented, a part which is hypopigmented. So vitiligo is depigmentation versus the hypopigmentation of leprosy. Right? So these are the usual differential diagnoses for tuberculoid leprosy. But you need to remember that a lesion, a single lesion, somewhat well defined, which has been which has remained unchanged for a long period of time, is very likely to be leprosy. So how you come at a diagnosis clinically is by checking the sensation. So you have to make sure that you check for sensation. When you are checking for sensation, like the tools that you can use are things like a toothpick or a ballpoint pen, or you can even fold a piece of paper like a OPD sheet in 4, so that you get a point like this, and that point can be used as your tool to check for sensation. So you should check for, you should put your tool on the normal skin, show the patient how it feels, and then ask the patient to point out to where you are touching with your tool. Right? Don't ask then and mother, because they might say yes even though they cannot feel. Right, so we move on to our second case. This is a 46-year-old male with multiple hypopigmented patches in the trunk. And there was a history of numbness in the medial aspect of the left hand. So my questions are, what is the most likely diagnosis and what are the differential diagnoses? So since I have started with leprosy, you might suspect that this is leprosy. Here, the things I would like you to appreciate are, this is leprosy. This is borderline tuberculoid leprosy. The second commonest presentation of leprosy. You get multiple hypopigmented patches which are more or less symmetrical. Right? You can see the lesions are fairly symmetrical. Lesions can occur on the trunk as well as on the limbs. The associated feature that tells you this is leprosy is the numbness. Now, this patient had a numbness in the left hand corresponding to the ulnar nerve distribution. So, what are our differential diagnoses for something like this? The first picture is actually a case of leprosy. The second picture is versicolor. Now, especially in this presentation, you may mistake it for versicolor because this is more like versicolor, like both are symmetrically distributed over the trunk. And usually even versicolor has been there for some time. So again, the features of versicolor like the fine scaling, the well demarcated nature. And if you go back to our first picture, you can see that certain areas of this lesion, the centers of the lesions are somewhat red. So versicolor is very unlikely to be red. Versicolor could be either white or dark, black, but not red, right? Especially if there is somebody with multiple hypopigmented patches and some kind of a neurological impairment. Think of leprosy. Now, before I move on, I would like to talk to you about neurological impairment also. Like most of us doctors have this tendency to do a fasting blood sugar when there is a neurological impairment. And if by any chance, if you find that the fasting blood sugar is high, you tend to attribute that numbness to diabetes. But if you go back to your basics, diabetic neuropathy usually occurs when somebody has had diabetes for about 10 years. So if you detect diabetes for the first time, and you attribute somebody's numbness to diabetes, I think you are forgetting your basics. Yes, there can be, because diabetes is quite common. About 20% of Sri Lankans are diabetic. And leprosy can coexist with diabetes. It's quite common, right? Okay, so similarly, leprosy and versicolor can coexist. Now, here you see in the first picture, this rather copper colored lesion which is somewhat raised from the surface is leprosy, but these lesions, the lesions which are below that are pityriasis versicolor. So you get versicolor and leprosy coexisting. In any of your patients who are having hypopigmented patches, if you are not sure of the diagnosis, best thing is, like if you cannot differentiate between versicolor and leprosy, best thing is to treat for versicolor and get the patient down and see whether there are any lesions remaining. But in this case, obviously the lesions look so different from each other, anybody can make the diagnosis that this is not versicolor. Now, what do we have here in the second picture? This is hypopigmented mycosis fungoides, which is the commonest type of cutaneous T-cell lymphoma seen in Sri Lankans. Actually, hypopigmented MF is much commoner than you guys think, right? So, this kind of hypopigmented patches which are mostly confined to covered areas of the body. We call these areas double covered areas. The trunk, the buttocks and the thighs. If you have these patches, multiple patches, like you can see that they are of several hues of hypopigmentation. Especially if they are confined to the covered areas of the body, you need to think of hypopigmented mycosis fungoides. Again, the message here is none of these are manageable in a primary care setting. Whether it is hypopigmented MF or leprosy, the patient has to be referred to a dermatologist, right? So, my suggestion to you is both these patients, if you saw any of these patients in your OPD, your first step should be to refer the patient. Like even in the first picture, the patient with coexisting leprosy and versicolor. I don't see any point in your treating versicolor and asking the patient to come back in 1 month here, right? So, basically the take home message about these multiple hypopigmented patches is Multiple hypopigmented patches are not only due to versicolor. Please remember that, right? So there are other more sinister reasons for multiple hypopigmented patches. So one thing is, if another point here is, most of our patients don't want to treat their versicolor. Aluhang for them is not a disease. So if you are not sure that this is aluhang, please refer the patient. Actually, I didn't include a picture. The other condition that can look like aluhang is, have any of you seen young patients in their 20s and early 30s, young people who develop aluhang-like lesions which are mostly in the midline of the trunk, mostly in the back, but also in the front also. Front also can be affected. Like, these people think this is versicolor, but it goes on like most of the times you don't have this well-defined aluhang-like lesions in the midline. The midline would be mostly hypopigmented, but you will have this kind of lesions towards the periphery, towards the sides of the body. This is called progressive macular hypomelanosis, which is a condition of young people seen mostly in South Asian skin. So that is another thing that has to be treated by a dermatologist. So most of these multiple hypopigmented patches, if your treatment for versicolor doesn't work, best thing is to send the patient, refer the patient to a dermatology unit. Okay. Case 3. A 48-year-old male presents with these asymptomatic lesions of the trunk and limbs for 5 months. Which leading questions would you ask? What are the differential diagnoses? Now, the feature I would like you to concentrate on here is the nature of these plaques. Now these are plaques, mostly these are plaques, but you get nodules as well and some papules also, but most are plaques. These are not uniformly flat plaques. These plaques are more kind of annular. The center is clear and the edges are raised. So these are annular plaques. If you liken this to any food that you know of, these look like donuts or uludu vade, right? So these kind of donut-like lesions are a hallmark of borderline forms of leprosy, right? So for your purposes, if you think of leprosy in a donut lesion, I think that will be very useful. The other features in these lesions are they are either skin colored or reddish. They are not hypopigmented. If you check for sensation in any of these lesions, the sensation would be normal, right? So this kind of combination of plaques, nodules and papules, mostly the donut lesions, the leading question that you should ask is for any neurological manifestations, especially the numbness of hands or feet. So what are our differential diagnoses here? When you get plaques, the most well-known plaque lesions in dermatology are the most well-known are psoriasis. So treated psoriasis. Actually, you wouldn't think of psoriasis here because there's no scaling at all. But treated psoriasis could look like plaques without any scaling, right? What are the other things? Now, this is another plaque which looks somewhat annular, somewhat like this, but this is just one lesion. This is a case of cutaneous TB, the condition we call lupus vulgaris. This is a picture from the web. This is a case of the plaque stage of cutaneous T-cell lymphoma. In Sri Lanka, we rarely see the plaque stage. 80% of our patients, I think, are hypopigmented variety, not the plaque stage of MF. What do we have here? Now, these are smaller lesions, multiple lesions, but look here. In the center, like you get some annular lesions. But these are, rather than plaques, these are papules, flat papules, which some of which look annular. This is granuloma annulare, multiple lesions of granuloma annulare. So this is of course psoriasis. So all these could come into the differential diagnosis. The diagnosis is very easy. In a lesion like this, we would go for a slit skin smear, which is a diagnostic test for, not the diagnostic test, but actually the test that can confirm the multibacillary types of leprosy. So we would go for a slit skin smear that is very likely to be positive. So patients like this, patients with leprosy who have lesions like this are the people who can transmit the disease to others. So actually why I included 3 cases of leprosy here is because we are, as the anti-leprosy campaign, we are doing a massive awareness campaign both for the public as well as for doctors about leprosy. One reason is we just passed the World Leprosy Day, but more than that, in Sri Lanka, the case detection of leprosy, we saw a drastic fall in case detection in the past 3 years with the COVID pandemic. So we have, in our rough estimate is, we have missed about 1,500 cases of leprosy who should have been diagnosed during the past 3 years from 2020 to 22. So we want all of you to diagnose those cases, I mean at least to suspect leprosy in your patients who have skin and neurological manifestations. So I just quickly run through the other clinical features of leprosy. The facial change, this is called the leonine face, the face that looks like a lion's face. The features are, there will be diffuse thickening on the facial skin, like they would say muna puravala dala, munura venas vela, a change in their appearance with, like here you can see in the forehead, like all of us have a slight protuberance of our forehead, but not this nodularity. And you can also appreciate that he has no eyebrows. If I remove these, you can see that the eyelashes are totally gone, right? And you get yellow nodules like this. Collapse of nasal bridge is very, very rare in Sri Lanka. And you can have thickening of eyebrows, loss of hair in the eyebrows, and papules or nodules in the chin. In addition to this, these people will have stuffiness of nose because now why they get a facial puffiness is because the organisms are now like underneath the skin like sheets. So the same thing happens under the mucosal surfaces, therefore they will have nasal stuffiness, nasal voice, and they are the people who will be putting out millions of bacilli when they are talking, sneezing, breathing, right? So they are the people who can infect the others. They are more a risk to their family members than to anybody else. The neurological manifestations, you can get thickened peripheral nerves. The commonest are the great auricular and the ulnar and radial cutaneous. There's no point in diagnosing somebody at this stage because this is already an established mobile ulnar claw plus muscle wasting, small muscle wasting. So this hand is now not fully functional. So we need to detect them at an early stage where they are complaining of early neurological symptoms like difficulty to perform fine tasks, like writing or doing anything fine with their fingers, and also numbness of the under the soles. If you detect a thickened tender nerve, it's supportive of leprosy. If you miss them at that stage, they will end up with non-healing ulcers like what we get here, which can lead either to auto or surgical amputation, right? So how do we treat leprosy? We have these cards. If you have less than 5 skin lesions, we treat them as paucibacillary leprosy with 2 drugs for 6 months. The green pack is for adults, the blue pack is for children. If it is multibacillary leprosy, where you have 6 or more patches or neurological involvement or a positive slit skin smear. We treat for 12 months with 3 drugs, which includes clofazimine, which is a dye. So, the patients will become dark when they are on treatment. Right. So, what's the primary care doctor's role in leprosy? Before the diagnosis, first thing is please suspect leprosy. Remember it in your differential diagnosis of skin lesions. Check for sensation if you have a suspicion. Examine for thickened nerves. So, I told you about pityriasis versicolor and leprosy coexisting. So, think about that. If you suspect leprosy, refer to the nearest skin clinic. If you mention leprosy in the referral, the patients will be given priority. If you are in Colombo, we have the Central Leprosy Clinic at room 12 OPD NHSL. Our clinic is a walk-in clinic. Even the patient himself can come and ask for opinion. We are open all 5 days of the week and also the morning of Saturday. Right. So, while the patient is on treatment, as the primary care doctor, you need to be aware of these things. You need to be aware of adverse effects due to treatment because some time ago, about a decade ago, like WHO or even we were not talking about side effects of leprosy treatment. But now we are seeing more and more cases of serious side effects. Now, leprosy is not a disease that kills anybody. So, if your treatment kills somebody, that is kind of criminal. Therefore, we need to make sure that our patients are safe while they are on our treatment. So, the serious adverse effects are symptoms of anemia, like they can develop dapsone-induced hemolysis, they can develop drug-induced hepatitis. If they have fever, like if one of our patients who is on leprosy treatment comes to you with a high fever, please stop the treatment because fever can be a sign of 2 very serious side effects, which are agranulocytosis or dapsone hypersensitivity syndrome. So, my message to you is, if any patients with leprosy develops high fever, especially during the first 3 months of their treatment, please stop the treatment. We can start it later. So, you need to be aware of reactions also. If there is new neurological impairment while they are on treatment, they need treatment with steroids. Therefore, please send them to our clinics immediately. Right? Okay, so that's the end of the leprosy part. So, we move on to other dermatological conditions. So, this is a 27-year-old male with this rash in the waist for the past 2 months. What other regions of the body would you examine? Now, I would like you to concentrate on this lesion. You can see this annular erythematous lesion, and then you can see the center of this lesion, which is not completely clear. This looks like the wood grain pattern, right? Okay. සිංහලෙන් කිව්වනම් ගහක් කපලා වෛරං ගහේ හොඳ ගහක් කුට්ටි කරලා වෛරං තියෙනවා. So that vairang pattern is there. Now, this is not the typical ringworm. What has happened here? So, to answer my questions, the other regions of the body that I would examine are the groins, any flexural areas. The groin is the commonest. So, especially because this is a young male, I would first think of the groin lesions. The other areas to examine would be the armpits and also the face, right? So, which previous medication is likely to have contributed to this appearance? Here, I am not going to criticize any of you, but what happens in most instances is, especially in an OPD, if you are not sure of the diagnosis, you do one of 2 things. One is you either give an antifungal and a steroid. මේ දෙක කලවම් කරලා ගන්න. Right? So, you ask them to mix the 2 and apply. If you are not sure whether it is infective or inflammatory, I think best thing is to treat the possible infection rather than thinking about using anti-inflammatory medications. The other thing that happens is you give an antifungal. If the patient says it's not getting better, you immediately move to a steroid. But the worst thing is you give this cocatathyl, the combination of steroid, antifungal and antibiotic. All these things that contain a GM at the end of the name, right? I will not give you any brand names, but all these things which contain either clobetasol, betamethasone or fluocinolone as a steroid, miconazole, and most of the times they contain gentamicin, right? So this combination of a steroid, gentamicin and miconazole or clotrimazole, this is the worst thing that has happened to Sri Lanka. This combination, even doctors think, okay, this contains all three possible medications. So even when I don't know the diagnosis, it should work either way. No, it doesn't work either way. It's only the steroid that works. That is why we have this wood grain pattern here. The actual appearance, the typical clinical appearance is masked by the use of steroids, right? So let's see how tinea looks like in people. So this is a typical tinea. You see the annular lesions. The center is sort of clearing. Again in this girl, now the center is clearing, the edges are active. Here again the edges are active, the center is clearing, right? Some more lesions, extensive lesions. Now when you get breast lesions, it's quite difficult to differentiate between nipple eczema and a tinea. Now this is typical tinea, right? Unfortunately, I don't have pictures of a tinea of the groins, right? Now, what is tinea incognito? Incognito means in disguise. So, tinea in disguise occurs when you are using these steroids, right? So, when steroids are used, the typical annularity of the lesions is gone, but still you can see, especially look at this lady here. How scaly are these lesions? The erythema and the scaling is still there, but you can't see a well-defined lesion like what you saw in the previous slide, right? And here, this patient, you can easily mistake this for a severe seborrheic dermatitis, right? So, you see, if you use steroids with antifungals, the issue is it's very difficult for you or the next doctor to come to a diagnosis. Now, this is a classic picture. This young girl had this itchy lesion in the axilla. You can still see the active edge of tinea. What has happened? This is here, she has got stretch marks. So, this was because of a combination of clobetasol, gentamicin and miconazole. I had a picture of that as well, I didn't use it, right? So, here, now this is iatrogenic striae, right? You have given these stretch marks to this young woman. Okay, she will not be able to wear a proper sleeveless dress now on. Now, you can still see the tinea lesions. So, my advice to doctors is, if your patient comes to you with itchy lesions of flexural areas, either the armpits, groins, under the breast, between the breast, first treat as a tinea. Use an antifungal, right? Don't add a steroid to your antifungal treatment. Now, before we move on, I would like to talk to you about what antifungals to use, right? Now, at the moment, I think at least for the past 6 years, I haven't used miconazole cream for any tinea infection. Not because I am working with the anti-leprosy campaign, but even when I was working at home agama, I just stopped using at home agama, right? Because people are not responding. The main reason we all suspect is this use of these combinations, and now organisms have started to become resistant or at least non-responsive to miconazole. So, personally, I don't use miconazole even in my clinic patients, right? So, the responsiveness to miconazole is very, very low. Clotrimazole, some patients respond, some don't. At the moment, ketoconazole is our best bet economically. The other things that you can add are terbinafine, cyclopirox, which is very, very difficult to find. There is only one brand of cyclopirox. At the moment, it's out of stock. The other things you can use are isoconazole or econazole, right? Econazole nitrate is available at the moment, and good old Whitfield ointment also can be used, especially if there are extensive lesions. Coming to oral antifungals, please remember like most of general practitioners would prefer to use fluconazole because it's cheaper and it's a once a week treatment. But basically, fluconazole's action is mostly against yeasts rather than dermatophytes. These are all due to dermatophytes. So, the response to fluconazole will be very, very low. Griseofulvin, some patients might respond, but most of the times it doesn't. The use of steroids is not the only reason why we have this problem. The other reason is actually our causative organism is now changing. Earlier, most of our fungal infections, tinea infections, were due to Trichophyton rubrum. Now, we have actually, Sri Lanka College of Dermatologists conducted the island-wide survey, island-wide research on the causative organism of tinea infections, and we found that now almost 50% of our tinea infections, or even a little bit over 50%, are due to this organism called Trichophyton mentagrophytes. This is more likely to be a zoonotic, animal fungus, and its response to the traditional antifungals is not that good. So at the moment, the two antifungals of choice as oral agents are itraconazole and terbinafine. So the problem is both are quite expensive. Like terbinafine, one tablet is at least 150 rupees. Itraconazole, a reasonable brand would be something like 200 rupees, and you have to give itraconazole 100 milligrams twice daily for at least 2 weeks. The minimum is 2 weeks. Other countries, they treat for at least 6 weeks, right? Here we can't afford to do that. So, with the present issues of non-availability of medications, especially at the moment, I don't think itraconazole is available. Even a cheaper brand is not available in the MSD, right? So, with the present issue, fungal infections are going to be a really big problem for us. Anyone who has had a fungal infection should know how difficult it is to tolerate the itching, right? So, my message to you is, if you think it is a fungal infection, please treat it with a proper antifungal or just immediately refer. Actually, my dermatologist colleagues would prefer to have the patients in their clinics rather than anybody else messing it up. Please don't use these triple combinations. If you use triple combinations, what you are actually doing is, you are actually not doing the best for your self-esteem also. When you use a triple combination, what you are doing is you are just shouting out loud that, okay, I don't know what it is, so I am using this cocatat thyle so that it will help in whatever way, right? So, please use your clinical judgment. if you are not sure of the diagnosis, treat the possible infection before you think about adding a steroid, right? Case 5. A young man with, he's 19, he has these itchy urticarial lesions in the trunk and the limbs for the past 4 weeks. There was no angioedema. He was treated with a short course of oral dexamethasone, fexofenadine 120 mg mane and Phenergan 25 mg nocte, like 3 days, 5 days, 1 week, like that. So he got temporary relief, and he is not taking the night tablet because he is studying for the exam, right? And it makes him drowsy. So, where have we gone wrong? The first thing is, we have given the wrong dose of fexofenadine. For an adult, he is 19, he is not a child. For an adult, we need to give, the minimum dose is 180 milligrams. You are using oral steroids every now and then, and you are using a sedating antihistamine, right, which is not helping him, especially in the case of school children or anyone who is studying. Sedating antihistamines cross the blood-brain barrier and they can affect the cognitive functions of people, whether it's a young man or even for you and me, right? So, use of sedating antihistamines should be avoided as much as possible, especially because for chronic urticaria, you need to treat it for a very long period. We are giving short duration treatments. You haven't considered the patient's lifestyle. I mean, no A-level student would take Piriton or Phenergan just before the exam, right? So, how can we, let's just, what is urticaria? Urticaria is repeated occurrence of short-lived cutaneous wheals accompanied by erythema and pruritus. They can range in size from very small to very large. Now, here you can see the well-defined lesions with an edge. The raised nature is not seen here, but the erythema and the swelling. The swelling on the face is very obvious, right? Typically, urticaria last for less than 24 hours, right? And the lesions should resolve without any residual pigmentation or any marks, except for scratch marks if you have been scratching so badly. Chronic urticaria is defined as urticaria lasting for more than 6 weeks. The lesion should occur several days a week or on a daily basis. It may last from months to years. Usually, chronic urticaria is idiopathic and identifiable causes usually you can't find one. Usually, chronic urticaria is not associated with IgE-mediated food allergy. So, I mean, sometimes your patients might come and say, Dr. Parippu kæවත් මේක කසනවා. Right? I mean, usually one thing you can advise your patients is, okay, it is not due to your drug, not due to your food or your drugs, right? About 40% will be accompanied by angioedema. Urticaria is considered a disease by itself, right? Not a symptom. It's common in females, especially in the middle age. So, US data says 70% of the disease may occur for more than 1 year. I think even this, in our setting, it may not be so bad, but I mean, I have seen patients who have had chronic urticaria for 5 years, 10 years. What are the other presentations of urticaria? Now, this is symptomatic dermographism. If you can remember what dermographism is, that is when you get this wheal and flare reaction in scratch marks. So, this patient has been scratching so badly, like you can see the back, like as if he has been beaten up, right? Or it could be, urticaria may sometimes present as annular lesions like what we see here. This is actually not scaling, right? There's no scaling here. Okay, how do we do the investigations in urticaria? Sometimes we see doctors investigating urticaria at the very first presentation, doing a full blood count and ESR. Usually that is not recommended. If it is acute urticaria, best thing is to look for a possible precipitating factor rather than investigating the urticaria. In chronic urticaria, the routine diagnostic workup should include ESR or CRP, a full blood count, omission of suspicious drugs like NSAIDs, and the rest of the diagnostic workup is based on history. Again, we see sometimes patients coming with extremely expensive investigations like vitamin D level and the allergy panel. Especially now if you think about the allergy panel, sometimes they come with even this, the food allergy panel which is done for like the prick test. Prick test is not for chronic urticaria, prick test is for acute allergy. So, in a case of chronic urticaria, if you do prick tests, this is completely out of, I mean, you are just doing something which is not related. Right? And remember, the allergy panel is very, very expensive. About 1 year ago, it cost about 30,000 rupees. So, now it should be something at least 50,000. So, I mean, before you make the patient spend that much of money, I think we need to think twice. Best thing is for you to manage, like if it is an acute case, even in the acute case, the minimum duration that I treat the patient is for 15 days, right? So the goal of treatment is absence of symptoms. So you need to treat the disease until it is gone. So it could be 15 days, it could be 15 months. You need to avoid possible triggers. So if the patient can identify triggers, you can stop those. No specific change in diet is needed unless it's specifically if the patient says, okay, I get it if I eat this, right? But generally I ask them to avoid taking all these artificial colorings and food additives, and also the most well-known things like tuna fish and that list. But I don't give a long list, right? The treatment should include the modern second generation antihistamines. The first line would be the usual dosage like 180 milligrams of fexofenadine, 10 milligrams of rupatadine, like that. The second line would be to increase the dose, up dosing. You can increase the doses up to 4 times the usual dose. So you can give 4 tablets of fexofenadine per day in divided doses, right? So you can give 20 milligrams of levocetirizine or desloratadine, right? You may use short courses of corticosteroids early in the disease, but later, let's say after 3 months or 6 months, there's no point in giving steroids. What are the drugs that can be used? Fexofenadine, levocetirizine, loratadine or desloratadine, montelukast, and the other thing is rupatadine. It's a new drug. The dose is 10 milligrams, the usual dose. So levocetirizine and desloratadine 5 milligrams, loratadine 10 milligrams. Montelukast, don't use 5 for an adult, it's 10 milligrams, right? So those are the drugs that can be used as first line treatments. I usually go for fexofenadine. You need to try and avoid sedating antihistamines. I told you the reason. Chronic urticaria, that is urticaria lasting for more than 6 weeks, I treat with the antihistamine or the combination that causes a complete clearance. That means you can't have 1 or 2 wheals occurring each day. No. You need to first get the combination, either updosed single antihistamine or 2 antihistamines that can cause complete clearance. Then you need to continue that dose for the next 3 months before you start before you start tailing off, right? So that is how we treat chronic urticaria. The last case, this young man who is a bank officer from Colombo working in Tambuttegama, he came with this painless nodule in the wrist for the past 7 months. He had been seen by several general practitioners, treated with antibiotics. This lesion progressed in spite of treatment. So what is this? This is cutaneous leishmaniasis. You can see that even though there's some crusting here, the lesion extends beyond that. The erythema is quite large, and if you touch this, you can feel that the entire area with erythema is indurated. It feels very firm to the touch. Right? So where have we gone wrong here by giving antibiotics? This is a large painless lesion. I mean, very unlikely to be acute infection when you have a painless lesion. He works in an area endemic for leishmaniasis. You all know that the entire north central province and the southern province, mostly the districts of Matara and Hambantota are endemic for leishmaniasis. Even in the western province, now there are certain pockets forming, especially around Meerigama, there is a pocket, right? So leishmaniasis was not considered in the differential diagnosis here, right? So I'll just take you through the basics of cutaneous leishmaniasis. It's due to a protozoan, Leishmania donovani. It's Leishmania donovani in Sri Lanka, not Leishmania tropica or major like in the Middle East. Transmitted by sandflies. It's endemic in certain areas of the country, which presents as an unhealing papule, which slowly progresses into a nodule, plaque or an ulcerated or crusted nodule. There's effective treatment available in dermatology units. At the moment, we don't have a ready supply of intralesional antimony, so we are trying alternative treatments at the moment. So the management would be for you to refer to the dermatology clinic. So if your patient has a long-standing asymptomatic lesion, especially in an exposed area, think of leishmaniasis and ask for a travel history, right? So you can see the passive case detection from 2009 to 2020. You can see the exponential rise in 2018. It almost doubled, right? We had 1,500 cases in 2017 and 2018 it more than doubled, right? Even in 2020, even with COVID, the drop was not so drastic as what we see for leprosy, right? So you see leishmaniasis is now here to stay. So it's our duty to suspect and diagnose these cases, right? So this is how the early lesions would present, like very small papules. Now here you can see how small the lesion is. It's like an acne lesion in an exposed area, so either in the arms, forearms or legs. Legs are a very rare site, which may then progress into nodules with a little crust in the center like what you see here. Then you may end up with not the exact progression, but the papule may progress into a plaque lesion. Still you can see the crusting, right? Even here there is crusting. Or they may end up with ulcerated lesions like what we see here. Sometimes there may be multiple lesions because there can be multiple bites, right? Now this location here, not a very common site, but I mean this man was a carpenter. When he worked, like he used to work in his vadumadu, which is mainly an open area, and his usual work attire is this vest, right? The usual baniyama. So this area is exposed. Right? These are the most difficult things to treat, the facial plaques, especially plaques occurring in females' faces. It's very, very difficult to treat, right? So you can see these asymptomatic plaques, right? Here, not even the crusting is seen, but in this lesion and this lesion, you can see a bit of crusting, right? Or you can get facial nodules like what we see here, or like this, or you can have lesions on the lips like this. Here our differential diagnosis was whether this is a carcinoma of the lip, right? So how do we suspect leishmaniasis? The typical lesions, asymptomatic, of long duration. The epidemiology, the patients are from southern, north central, northwestern especially Kurunegala, and also Ratnapura also. Last few years we saw new pockets emerging. Even in Colombo district, when before I left Homagama, I had been seeing certain pocket forming in Padukka area, right? So we need to be a little bit aware. I don't know what's happening now, but my feeling is now we are getting pockets all over the country because the sandfly can be found all over the country. So if you have enough patience, then pockets can form. I have a very good experience about new pockets forming. I was in Polonnaruwa from 2008 to 12, and after the war ended in 2009, large number of LTT cadres were brought to rehabilitation camps in the Valikanda MOH area, places like Kandakadu. So these patients, while they were in they were at Chetikulam. Immediately after capture, they were in Chetikulam, and then only they were brought to Valikanda. So they had acquired leishmaniasis while in Chetikulam, right? So in 2010, about 1/3 of my patients were from this group who were like captured LTT cadres. And then we started seeing patients coming from army personnel who were manning these camps, and then people who were living around the camps. So I saw, while during my 4 years in Polonnaruwa, I saw pockets forming in certain areas, like certain areas where there were camps, simply because it was brought from the north by these people who were brought to Velikanda, and then because the sandfly is there, they got bitten, and then the disease spread to the people who were outside the camp as well, right? So pockets can form like that because the sandfly, the phlebotomous sandfly is, I think, found all over the country. So the travel history is extremely important. Like now, last few years, you have been bombarded with messages from the anti-malaria campaign. Ask for a travel history, overseas travel history in case of fever. Like that, my message to you is ask for a travel history within the country, especially Vandana Gaman to Anuradhapura Polonnaruwa or to Kataragama, right? So ask about those in your history. If you see these asymptomatic nodular lesions occurring in exposed areas of the body. Very rarely persons returning from the Middle East may have multiple lesions, especially people who have been working in Saudi as housemaids. They came with multiple lesions which were probably due to Leishmania tropica rather than Leishmania donovani. So how do you manage a suspected case? You can try an adequate course of antibiotic like flucloxacillin or erythromycin for 5 days, especially if the lesion is only a few days or like 2 or 3 weeks duration. If they are not responding to the antibiotic, refer to the nearest dermatology clinic with a query of leishmaniasis. Again, if you query leishmaniasis or leprosy, they are very likely to be given priority. I mean, they may not have to wait in the waiting list, the usual waiting list, right? So please do that. Why is it important to treat cutaneous leishmaniasis? Because currently the best control measure is treatment of cases to reduce the reservoir of infection, and we see the number of cases is rapidly increasing. Self-healing may occur but can lead to scarring. Chronicity may be a problem. I mean, I had a patient who had a lesion like this. When I was working in Polonnaruwa, this patient had the lesion like this, and then this patient we treated and the lesion healed. After some time, it started to spread from the edges. 4 years ago, about 4 years after leaving Polonnaruwa, when I went back to Polonnaruwa for a regional clinical meeting of the Dermatology College, still that patient was there. Because the lesion was spreading, like it's healing in the center, but it's spreading. So chronicity may be a problem. Again, it's not more. Okay. So basically, those are the reasons why you should treat cutaneous leishmaniasis. In addition to that, I told you that the organism for cutaneous leishmaniasis in Sri Lanka is Leishmania donovani. Leishmania donovani, if you all remember your parasitology, is the organism that causes visceral leishmaniasis in other countries. So our organism is very closely related to the organism causing visceral leishmaniasis in India and Bangladesh. And in Sri Lanka also, we have at least 9 reported cases of visceral leishmaniasis, right? But don't get panicked. Cutaneous leishmaniasis does not lead to visceral leishmaniasis, but the organism is viscerotrophic. Therefore, it's very important for us to control this organism and like not allow it to become a very common cause for visceral leishmaniasis, right? And not only visceral, we have had mucosal leishmaniasis also. I showed you pictures of mucosal involvement. We have had one case which looked very much like cutaneous leishmaniasis also. So, I mean, in Sri Lanka, we have had all 3 forms like visceral, cutaneous and mucosal leishmaniasis caused by Leishmania donovani. So, it's extremely important that all doctors are aware of cutaneous leishmaniasis and that they think of leishmaniasis in their differential diagnosis and that they refer these patients to the nearest dermatology clinic. So that's the end of my presentation. Thank you so much for being with us today. And I think there may be a few questions.
Thank you very much, madam, for that interesting and very informative lecture. And we have one question that is, what is the best treatment for pityriasis versicolor and the duration?
Right. Pityriasis versicolor, if you all can remember, is due to yeasts. So you can treat pityriasis versicolor with like my preferred antifungal is again ketoconazole. You can use others. Terbinafine also can be used, especially the topical terbinafine, right? Ketoconazole, terbinafine both can be used, and you can use these antifungal shampoos, especially if selenium sulfide is available, that can be used. At the moment, I don't think selenium sulfide shampoos are available in Sri Lanka, so sometimes I use ketoconazole shampoos also. If it is, especially if it is very extensive, and if you see follicular lesions, I treat them with oral antifungals. Here you can use fluconazole. The dose is not 150 milligram weekly, but the recommended dose is 50 milligram daily for 10 to 15 days, depending on how extensive that is. And one thing you need to remember about pityriasis versicolor is that the organism causing pityriasis versicolor is part of our normal flora. Therefore, they can cause, like, even if you don't use the treatment for adequate duration, they may get recurrences. So, usually my recommendation is to use topicals for a minimum of 1 month, oral for a minimum of 10 to 15 days. And also treatment of fomites, like, boiling or at least ironing your clothes that come into contact with the lesions, the towel, the clothes, that is also important, because otherwise you can get reinfected, right? So that is how we treat pityriasis versicolor.
Thank you, madam, for your elaborative answer. And we have another few more questions. The next question is, acute urticaria, should we have to treat first only with antihistamines, not with steroids?
Acute urticaria is very likely to respond to steroids also. So, what I usually do is I give a short course of steroids, either dexamethasone or prednisolone, plus antihistamines. And usually I continue my antihistamines for a minimum of 2 weeks.
Thank you, madam. And the next question is, if facial leishmaniasis is present, how we can treat that?
Yes. Leishmaniasis, if it is just 1 or 2 lesions, especially in a limb or the trunk, we can use intralesional sodium stibogluconate. When it is not available, our second line treatments are things like we use the IV preparation of metronidazole. I think even that is now not of, the availability is a problem. So now my colleagues who are treating leishmaniasis are actually now looking for other preparations. But if it is facial, especially the lip ones, the nose ones that I showed you, they need intramuscular stibogluconate 10 milligrams per kg per day for a duration of 20 days. So they have to be managed in a dermatology clinic where they have to come for injections every day. There are certain other drugs that can be added to this, but they alone on their own will not help. Like one such drug is levamisole. Sometimes I add levamisole to my other treatments, especially if they are having very extensive lesions.
There's one more question, madam. If there's facial leprosy without numbness, how can we diagnose that?
Yes, if there's facial leprosy without numbness, now we all know that facial lesions can be without numbness, right? Therefore, one thing is like sometimes, especially now, if you saw that first picture, we didn't do a biopsy, but if the lesion is somewhat, let's say it's not typical, we go for a skin biopsy. I didn't talk to you a lot about diagnosis of leprosy, but especially the hypopigmented patches, they are very unlikely to have a positive skin smear, right? So we rarely do smears, but sometimes we do biopsies. We can do a small punch biopsy even in a facial lesion.
There's another question, madam. Can you please elaborate more in treating tinea infection with oral medication, duration and response?
Right. Tinea infections, if you the usual the clinical guides that I use are, if it is just one region, let's say groin only, you can try with topical antifungals, something like ketoconazole and terbinafine. When you are advising your patient to use the treatment, you have to ask them, like show them that, okay, this is the lesion, apply your cream on the lesion as well as around the lesion, because the organism is found outside the lesion as well. And so that is one thing. And you have to continue your topical antifungals for a minimum of 6 weeks. That's what I usually tell them. The orals, what I usually do is, if you are giving terbinafine, you have to give it for a minimum of 1 month, 250 milligram daily for 1 month. If you are giving itraconazole, what I usually do is give 100 milligram BD. Don't give 100 milligram daily, that's useless, you are just wasting the patient's money. 100 milligram BD for a minimum of 2 weeks, and then I get them down and see the response. If the response is good, I can stop it. If it is not good, then I have to give another repeated course of at least another 2 weeks. So, especially in countries like India, their duration of treatment is about 6 weeks. Now here we can't do it because it's not available in the hospital and patient can't afford. Like a correct course of itraconazole is going to cost the patient something like 6,500 rupees for 2 weeks. So if you have to do it for 6 weeks, it's something like 20,000 rupees, right? 20,000 rupees for 6 weeks. So if four members of the family are having extensive tinea, that's the end of that, right? So they won't be able to afford their food. That's the problem.
I hope this is the final question for you, madam. Can you please explain the chronic urticaria treatment again?
Right. Chronic urticaria, the first thing is you can start with the usual dose of antihistamines. Let's say you prefer to use fexofenadine. You start an adult on fexofenadine 180 milligram daily and see the response. If they are responding, like if there are no lesions at all, you can continue this same thing for 3 months. If you are not happy with the control, let's say they are having occasional wheals, like say 2 to 3 times a week, you can either increase the dose, double the dose, or you can double the dose, but you can also add a second antihistamine like rupatadine or desloratadine or levocetirizine. So once you achieve the preferred control, which is like no wheals, no urticaria at all at any day, then you continue this same treatment for 3 months, then you reduce one by one, right? I saw a question about management of urticaria in the pediatric age group. It's more or less the same, but I have seen that especially during the first few weeks of urticaria in children, it's very difficult for us to control. So they need several antihistamines. and they need oral steroids, you should, as far as I can remember, fexofenadine cannot be used in children less than 6 years of age. So pediatric age group, when you are deciding on treatment, you will have to refer to the BNF before you decide on starting a treatment.
Thank you very much, Madam, for clarifying all the questions which we received. And it comes to the end of the third session of the academic hour program. Thank you very much for joining us and hope to see you in 2 weeks' time. Have a good day.